Greetings. Let us talk about the basic principles of endoscopic evaluation when you see a patient with GERD. These are my acknowledgements, so please take time to read. When you have a patient with heartburn, you should consider endoscopy if the heartburn is chronic. You should also consider endoscopy when a patient with heartburn presents with other symptoms, some red flags. If they have dysphagia, or if they have hematemesis, or if they have anemia, or if they have weight loss, or if they have regurgitation of food, it may be something other than typical gastroesophageal reflux disease. When it comes to endoscopy in a patient with heartburn, you should follow certain principles and evaluate the lower esophagus, the crura, and the flap valve. So, in a patient with heartburn, it is related to acid reflux, and that reflux, if it is severe and the esophageal lining is weak, it may develop inflammation, and if it is prolonged, it may develop a change in the lining, that is metaplastic lining, from squamous to columnar lining. In addition to assessing the lower end of the esophagus for inflammation and metaplasia, as you go into the stomach, stop and think about the diaphragmatic hiatus and the quality of the crura and phrenicoesophageal ligament, the integrity of crura and phrenicoesophageal ligament. So when you are just about to enter into the stomach, just wait in the esophagus and see what is happening as the patient takes a breath, and is there a diaphragmatic hiatus pinch or not. After you enter into the stomach, you check the lower esophageal sphincter and the flap valve by retroflexing your endoscope and checking the integrity of the flap valve. So, commenting on these three components is important for your subsequent management of the patient. So, when it comes to the lining, you are commenting whether the lining is completely normal or the patient has developed erosions or erosive esophagitis. And you also comment whether there is a metaplastic change, which is defined as Barrett's esophagus, if the biopsies show intestinal metaplastic change. And as you think about the crura, if the crura are separated and the diaphragmatic hiatus becomes bigger, the stomach may herniate. And in that case, you comment on the presence or absence of hiatal hernia. Hiatal hernia tells you what is the status of the crura and phrenicoesophageal ligaments. And if you see no hiatal hernia, then you go down into the stomach, retroflex, look at the flap valve integrity. And this you classify based on the American Foregut Society grading. Normal flap valve is full, and in the early stages of laxness of the flap valve, you may be able to see some gap between the scope and the lesser curve. and the flap valve becomes thinner. So keep in mind, any patient with heartburn, comment on the following things. And in your own follow-up clinic note, when you comment on gastroesophageal reflux disease, in addition to commenting on the symptom burden, response to treatment, you want to include, is there erosive esophagitis or not? Is there Barrett's esophagus or not? Is there a hiatal hernia or not? And what is the status of the flap valve integrity? I hope this is helpful, and we will talk about how do you assess erosive esophagitis, how do you grade it, and then how do you assess Barrett's esophagus. And then we'll also talk about the AFS grade of hiatal hernias and flap valve. Thank you.